I'll start first. Is that okay? Thank you everyone for attending our Lincolnshire Grand Rounds. Sorry for the the incorrect number of the Grand Round. This is the 10th one. So our guest today is Mr. Hani Nasef, consultant head and neck thyroid and parathyroid in Portsmouth University Hospital. Thank you, Hani. You can start. Thank you.
Thank you very much, Abdurrahman. Good evening, everyone. My name is Hani Nasef. I'm an ENT head and neck surgeon in Portsmouth Hospital University. We are also doing endocrine surgery, thyroid and parathyroid. Today, I'm going to discuss briefly the parathyroid conditions, parathyroid disease, hyperparathyroidism, starting from the basic learning till the standard management, including all the challenges. I would call it challenges because there is a lot of uncertainty and there is no clear guidelines or practice that can everyone follow and that can apply for every patient. So to start, this is our agenda for today. We will start discussing symptoms, indications, contraindications for parathyroid operations, preoperative preparation, investigations for the disease, parathyroidectomy operation, postoperative management. And I just would like to thank my friend and colleague, Mr. Matt Ward. He is my parathyroid surgeon colleague in Queen Alexandra Hospital, Portsmouth, and we do many cases together, and he has helped me a lot in this presentation, and I think he is in the meeting today. To start, this is a quick brief about the calcium metabolism and how the parathyroid hormone is related to that. We all know that the parathyroid glands are situated behind the thyroid gland, and it's responsible for secreting the parathyroid hormone. Parathyroid hormone has main effects on two organs, the kidney and the bones. The main function of the parathyroid hormone is to increase the calcium concentration in the blood. This is the main function. So on the bone, it stimulates osteoclasts to produce more calcium in the blood, and on the kidneys, it allows stimulate calcium reabsorption and phosphate excretion. And on the kidney, it also stimulates the active conversion of inactive form of vitamin D to the active form of vitamin D. Vitamin D is very, very important in the calcium metabolism. As you all know, the vitamin D comes from this food and from sun exposure in the form of 25 hydroxy vitamin D cholecalciferol, and the hydroxylation, the second hydroxylation happen in the kidney to be 125 cholecalciferol, which is calcitriol, the active form, and this vitamin D helps in the absorption of calcium and phosphorus from the intestine. So the net results of all of that is increased calcium concentration in the blood. And there is a feedback mechanism which inhibits more parathyroid hormone secretion when the calcium level increase. This is very important, and we will review this point later. There's a lot of causes of hypercalcemia. Today in our talk, we'll just focus on one thing, which is the most important, most common, which is the primary hyperparathyroidism. Primary hyperparathyroidism means that the... Hello?
Hello?
The primary hyperparathyroidism is caused by increased secretion of parathyroid hormone, which causes high calcium level. Secondary hyperparathyroidism means that there is a cause for this increased parathyroid hormone level, usually due to low calcium level. This happens usually in renal conditions or other diseases. Tertiary hyperparathyroidism is an autonomous secretion of the parathyroid hormone as a result of long-term stimulation by low calcium level in the renal condition, which in the end leads to a high calcium level. There are other causes of hypercalcemia not related to the parathyroid hormone, which is usually cancer. Myeloma is a very, very common cause. Lithium therapy are also very common cause, one of the common causes. Also excessive calcium intake and medications. This also will, when you see a patient with hypercalcemia, the first investigation to request is to see the parathyroid hormone level. Parathyroid hormone level is only elevated in two conditions, which is the primary hyperparathyroidism and the familial hypocalciuric hypercalcemia, FHH. So when you have a patient with high calcium level and high parathyroid hormone level, you just need to exclude one condition. And if it's not that condition, then it is hyperparathyroidism, usually primary. All other causes of hypercalcemia will lead to inhibition of the parathyroid hormone secretion, including the paraneoplastic vitamin D excess, multiple myeloma, and other conditions. The differentiation between the FHH and the primary hyperparathyroidism is by finding the calcium ratio or the calcium in the blood. In primary hyperparathyroidism, it's increased because the calcium level has increased and it goes in the kidneys, while in the FHH, it's hypocalciuric. So the calcium creatinine ratio is actually low, and the calcium excretion in the blood is very low. There are other conditions which are actually a hyperparathyroidism, but it's not the simple primary one, it's the syndromic genetic one. In these conditions, we have the FHH as we discussed, and the MEN, multiple endocrine neoplasia syndrome. The MEN one, which is pituitary, pancreatic tumors, gastrinoma, and the hyperparathyroidism. This condition happened in young age, about below 30, and it associated with the gene MEN1. MEN2 is more dangerous condition affecting the also young people, causing medullary thyroid cancer and pheochromocytoma and hyperparathyroidism. In this condition, there is an RET mutation, and of course, the management of this condition is a multidisciplinary, and it involves usually a thyroid operation because of the medullary thyroid cancer. FHH, as we have discussed and we'll discuss later, is associated with CASR gene, calcium sensing receptor gene. FHH is the familiar hypocalciuric hypercalcemia. It's rare, but it is important because it is the main differential diagnosis and it's biochemically indistinguishable from the primary hyperparathyroidism. The only difference is the 24-hour urinary calcium, which is low. So it's very important when you see a patient with high calcium level and high parathyroid hormone level, you should exclude the FHH by requesting a urinary calcium to creatinine ratio, and it's usually low. Usually there is a family history of this condition. It is few symptoms, mild condition, not very high calcium, not very high parathyroid hormone. It doesn't need surgical intervention, so you don't need to do parathyroid operation in these patients. And actually, if you do parathyroidectomy in these patients, you're not helping because the patient will continue to have high calcium level. Hyperparathyroidism, as we mentioned, there's 3 subtypes: primary, secondary, and tertiary. The primary one, when the parathyroid hormone is high, as a result of that, the calcium is high, phosphate might be low, alkaline phosphatase might be increased because of the osteolytic activity in the bone. The secondary, it's secondary to the low calcium level. When you have a low calcium level, as a response to that, the parathyroid hormone will be high. This usually happens in renal disease or low supplement. Tertiary is where the parathyroid hormone is autonomously high. As a result of that, the calcium is also high. This happens in end stage renal disease after renal transplant sometimes. Typically, the parathyroid hormone happen in the middle-aged or older women, and when it happens in young age, we think more about the genetic conditions. You have to exclude men, FHH, and other genetic conditions. Also, when it's a young man with a very high parathyroid hormone and very high calcium, you might suspect cancer, but this will be obvious on the scans. The epidemiology of the primary hyperparathyroidism in the UK, the incidence is about from 34 to 120 for each 100,000 in women. It's more than in men, and the prevalence from 76 to 133 in women, from 30 to 85 in 100,000 men. Symptoms of hyperparathyroidism is just the high calcium level. So this is one of the challenges because it's non-specific, it's vague. When it's mild, there's a lot of other differential diagnosis. So as previously mentioned, stones, bones, groans, and psychiatric moans. So stones is associated with polyuria, and kidney stones, nephrocalcinosis. Bones is associated with, because the calcium is coming from the bones, and so the bone and the joints are affected. There is a weaker bones, osteoporosis might happen, osteopenia might happen, fractures might happen. Associated with groans, so constipation and GIT problems. Psychiatric moan, patient usually, if you speak with a patient with high calcium level, usually there is a brain fog. This is what they also all say. Many of them would say that. Slow thinking, very bad memory, feeling fatigue, depression, and mood swings sometimes might lead to psychosis. Also, cardiac condition might be affected, but this is in a very high calcium. Usually there is effect causing heart block, might affect the heart rate and hypertension. Next, the challenge here is the indication of parathyroid surgery, because it's in many patients it's a mild condition affecting only the quality of life. So when to do any intervention? This is a nice guidelines. You will find this on the nice web page. It's, I have to say, it's not specific. It doesn't give you a lot of information, and there is a lot of vague recommendations here. But we can say that here they say when to refer the patient from when the patient needs to be referred from the primary care to a parathyroid surgery unit. They say here when there is a lot of symptoms, which is thirsty, excessive urination, constipation, or osteoporosis, fractures or stones, or the adjusted calcium is above 2.85, but that's not very helpful. So in our hospital, we would see a lot of patients with high parathyroid hormone level, hyperparathyroidism. We need to decide which of these patients would benefit from operation. So we have a hard indication and what we call a softer indication. So hard indication would be patients who is having symptoms. Number one, a patient with a kidney stone. Number two, patient who developed fracture before. These two indications, very strong indications for doing an operation. Or very high calcium patient who was admitted in the hospital because of very high calcium above 3 and dehydration, who needs admission to be given IV fluids. Other than that, it would be any symptomatic patient. Any symptomatic patient who would benefit from an operation is an indication. And then if the patient doesn't have any of these, he doesn't have symptoms, he doesn't have kidney stones, he doesn't have fractures, the indication would be if the patient is likely to progress or the patient have a subclinical end organ damage. How to identify these groups? Patients who are younger than 50 are probably likely to progress. So if he would live like 20, 30 years more, then it's very likely that this condition that cannot be cured, there is no medical treatment for them, they would progress. So they would benefit from having a parathyroid operation. And just would like to say other indications, actually, this is more obvious in the American guidelines. So the first international workshop on asymptomatic primary hyperparathyroidism, they have decided that these are the indications to do an operation in asymptomatic patient. If the serum calcium is high, if the bone density is more than 2.5 standard deviation below average, if the patient has a asymptomatic fracture, or if the patient have a more secretion of calcium in the urine, or low glomerular filtration rate, so renal deterioration, or then less than 50. They have added a very nice sentence here that asymptomatic patients who do not meet any of these surgical intervention criteria, then they can still have the operation because it's the only cure. Actually, in our hospital, we would probably try to manage all of them unless they are unfit for operation. We sometimes even manage what's called the normocalcemic hyperparathyroidism or the normohormonal hyperparathyroidism. Normocalcemic hyperparathyroidism, when the patient have symptoms, high parathyroid hormone level, but upper normal range of the calcium. It's sometimes considered an early hyperparathyroidism, and most of these patients would benefit from operation. You can discuss with them that they might have benefit from that, and we need to bring the parathyroid hormone level to the normal range. Normal hormonal is a patient with high calcium level, but an unsuppressed parathyroid hormone level. Any patient with high calcium level, you would expect the parathyroid hormone to be low, but in this group of patients, the parathyroid hormone is not suppressed, so it's in the high normal range. This group of patients also would benefit from surgical intervention. In our hospital, we are endocrine. This is the endocrine unit. We are 2 endocrine surgeons, 3 endocrine surgeons, 2 doing parathyroid, and we have the endocrinologist, 3 consultants. We see about 400 patients of endocrine cases per year. We do about from 250 to 300 parathyroid operations per year. We do joint ENT endocrine clinic parathyroid dedicated for the parathyroid disease. We do it twice a month. We see about 150 patients, and we do on average about from 50 to 80 patients parathyroid operations per year. What are the contraindications for the parathyroid surgery? Actually, there aren't, if just only the patient is not fit. So an elderly patient, 80s or 90s, who have mild disease or can't have a general anesthesia, then it's reasonable not to offer them that. Instead, there's the cinacalcet. Cinacalcet is a drug which causes block the calcium receptors. It leads to lower the parathyroid hormone level, lower the calcium level, but it's not without side effects, and it's not a permanent solution. And this is the only contraindication for the operation. So how to prepare the patient for the parathyroid surgery? This is one of the challenges, because there's a lot of options and it's not obvious what is best. But of course, start with, we do the biochemistry first. We do the calcium level, parathyroid hormone level. This is very important, and this will give you an idea if this is actually parathyroid hormone, parathyroidism or not, if it's primary or secondary, tertiary or not. Then you need to do renal function to see the kidney function. Has it been affected? Does the patient have a renal failure? Vitamin D to make sure the patient doesn't have a secondary because of low vitamin D, low calcium. You need to do, as we discussed, the 24-hour urine to differentiate between FHH and the hyperparathyroidism. Serum magnesium chloride, alkaline phosphatase are other biochemical tests you might consider, and this is just an adjunct which help you in the management of the disease if the patient has a hyperparathyroidism. Then we will do the radiological investigation. These radiological investigations has improved over time. In the past, there was no obvious scan that would help you. All the patient would have a standard bilateral exploration, but with the advancement in the radiological investigation, now it's possible to identify the 1 or more enlarged parathyroid glands before the operation. then you can offer the patient a more targeted operation, less operative time, less possibility of complication, and still high success rate. So this would allow for the minimal access parathyroidectomy. In our unit, we don't do that. We do what's called targeted operation, which is just open on the enlarged gland, remove it, and then see if this is successful or not. We don't do the minimal access parathyroidectomy. In the investigations, there are two modalities, two broad categories, the non-invasive methods or the invasive methods. Non-invasive methods is give you an idea about the structure and the functional state of the gland, doing an ultrasound and nuclear medicine scan and other scans like CT and MRI scan. Invasive methods is selective venous sampling, parathyroid arteriography, or fine needle aspiration. Not all of them are standard and done in all cases, but sometimes we do selective venous sampling. First is the ultrasound. This is the first investigation to request. It's very standard, but as we all know, it's highly operator dependent. It depends on how expert the radiologist or rather the radiographer is. Sometimes the surgeon would do this to make sure. In our unit, our surgical team actually do the ultrasound ourselves in the theater, which is actually a very, very helpful tool. So it has been mentioned that the specificity of the parathyroid of the ultrasound in the hyperparathyroidism range from 51 to 96. This is the sensitivity, the specificity from 90 to 89. So sometimes if the radiographer is not very experienced, it will not be able to find the parathyroid gland because it needs a lot of experience. And when it's large, the sensitivity is more, as expected. But when it's small, less than 500 microgram, then the sensitivity is actually less. When the patient have a concomitant multinodular goiter or multiglandular disease, multiple adenomas, then the ultrasound become less sensitive. This is the standard picture of the inferior parathyroid adenoma. Can you see here? This is the thyroid gland. And below it, you can see this is the adenoma. It's hypoechoic, darker in color in relation to the thyroid gland. And you would expect if you use the Doppler to see a vessel, polar vessel going into that. And this is the superior adenoma. Superior adenoma actually situated behind the thyroid gland. So this is the thyroid gland. And behind it, you can see this is a hypoechoic structure, which is the upper parathyroid adenoma. Ultrasound has a lot of advantages: no radiation exposure, non-invasive, more or less inexpensive and easy, but it has a lot of limitations. It's limited by the operator, if he or she is experienced or not. In a lot of sites where the parathyroid gland adenoma is ectopic, deep in the neck, low in the mediastinum, the ultrasound cannot see them. So we need another modality. The second important modality is the system-EB scan, the nuclear medicine scan. System-EB is used in the nuclear medicine. It's accumulate almost exclusively in the mitochondria. So it's taken by the thyroid, parathyroid, and the salivary, but it is retained longer in the parathyroid gland than the thyroid. So when it's used, you can take the dual phase, take early picture, then late pictures, and then the late pictures, it will be only the parathyroid glands. It's taken in the oxyphil cells of the hyperparathyroidism. So this is a dual phase. As you can see, in the after administration, it's taken by the thyroid and the submandibular gland. And when time passes, it's only retained in the parathyroid. You can identify the parathyroid by doing that. This was in the past a standard investigation, but then with advances, we have seen the SPECT, which is giving you higher resolution images. then it can give you where exactly is this enlarged gland. If it's anterior or posterior in the neck, then you can identify or have a focused approach more. So it has improved sensitivity over the system AB alone, and this is how it looks like. You can have picture like axial, coronal, and sagittal, and you can see exactly where is the gland, and then you can expect where to find it. With more advances, now the standard is the SPECT CT, when there is an integration between the SPECT and the CT scanner and the gamma camera. Then it gives you like, and then you can have this fused scan. This is fusion between both the CT scan and the gamma camera. Can tell you exactly on the CT scan where this parathyroid adenoma is. You would know if it's upper or lower, if it's up high in the neck, if it's in the upper mediastinum. So it gives you a lot of information. So this is the standard inferior adenoma. It's actually in front of the trachea, below the thyroid gland level, at the suprasternal notch. This is very standard site for the lower parathyroid adenoma. And this is the standard superior adenoma. It's behind the thyroid gland, in the tracheoesophageal groove. It can be high, it can be low in the neck, but it is behind. And then there is a subtraction scan, which is not used as a standard, so giving dual isotopes. So radio tracer that accumulates in both the thyroid and parathyroid, which is system AB, and then another radio tracer, which is only thyroid specific, which is usually radioiodine or technetium, and then computer software used to subtract, and then you can know after the subtraction where is the parathyroid adenoma, which has it's only taken by system AB. But this is not standard in many places. CT scan has had bigger and bigger importance in that in this disease. So now in our center, and actually in many centers, they would consider doing what's called the 4D CT scan, which is a multi-phase. Why it's called 4D? Because it's give you the time. So you will do the scan without contrast, and arterial phase, and venous phase, and late venous phase. So it depends on a fact that there is a rapid contrast uptake and wash out of the parathyroid adenoma. It's rapid, it's quicker than the thyroid, and the wash out is quicker actually than the lymph nodes and the thyroid. So it has this specific feature of contrast enhancement, which allows you for the identification. So the role of the CT scan in this disease has grown a lot. It's usually very important in the condition where there is the scans are not concordant, or you can't see it on the scan, or in case you're doing a division surgery. So this is a case where the parathyroid adenoma was found. It was behind the thyroid gland in the tracheoesophageal groove. This is an upper adenoma on the left side. This is another upper adenoma on the left side, but it's large, less enhancement, but it's large in the tracheoesophageal groove. And this is where to find the lower adenoma below the thyroid gland in the suprasternal notch. MRI scan actually is less commonly used, sometimes used only in cases where you can't do a CT scan like pregnant women, or sometimes it's in the mediastinal disease, you want more anatomical details, but it's not standard. PET CT scan has been identified recently as a tool to do that. Choline's PET CT scan is very specific for the parathyroid disease, but it's not currently standard in our hospital. It's not funded for the parathyroid disease. It's funded for other conditions, but not the parathyroid. Invasive techniques are usually not the first technique to use. In our hospital, we use the selective venous sampling, which is take blood sample from the jugular, innominate, and the right atrium, right and left, upper and low, and then it can tell you a lot of information. When there is 1.5 to 2-fold increase the parathyroid hormone level, this allows for identification. You would know if the parathyroid adenoma would be expected to be on the left or the right, higher or lower in the neck or in the mediastinum. I have to say it's not a very accurate tool. It just gives you an idea where to start. In our experience, even if it tells you it's more probably on the right, it's not. It doesn't have to be on the right, but it's just a tool. We use it before doing the 4-gland exploration. After discussing all of this condition, what is the best investigation? That's not standard. This is one of the challenges. In our hospital, we have this approach, which we think is just reasonable. We need 2 concordant scans. We usually start by the ultrasound and the system CT, SPECT CT scan. If both of them showing the same thing, then we have a functional scan, an anatomical scan. Then we accept that. We proceed based on that. If both scans doesn't show the adenoma or they are not concordant, we proceed with the second line, which now currently we do the CT scan, multi-phase 4D CT scan. Then if this CT scan doesn't show anything, then we would proceed for the selective venous sampling, which just gives you an idea where to start. Shall we start on the right or the left, or we expect to find it in the mediastinum, in the thymus? And then usually we start doing the operation. Cooling PET CT scan is not standard. Sometimes we managed to do it, but it's not standard and it's not funded. Sometimes before the operation, we need to optimize our patient. We need to minimize the risk of the operation. Usually the risks after the operation, either if you have a very if the calcium is liter, we will admit the patient for 1 day before the operation to give 3 liters of IV fluid, saline. We not supposed to give any fluid that is calcium. And patients who are having a revision or multiple revision surgery, multi-gland disease, we expect the calcium to drop very quickly after the operation. You need to consider giving vitamin D supplement before the operation. Then we will proceed with the parathyroidectomy. So how many parathyroids do I need to look for? If you have diagnosis of the hyperparathyroidism, you would expect most of these patients will have 1 single adenoma. In the literature, it's mentioned that single adenoma is found in 85% of the disease. Double adenoma is about 10%, hyperplasia 5%. This is different from our case series, and I will mention this later. But the idea is right. It's mostly single adenoma, sometimes double, very rarely hyperplasia, and very, very, very rarely to find the parathyroid cancer. If you find cancer, the usual management is to do ipsilateral hemithyroidectomy, central neck dissection, and parathyroidectomy as an in-block resection. There are 2 ways of doing this operation, either the targeted parathyroidectomy or the bilateral 4-gland exploration. There are advantages and disadvantages for both of them. The targeted parathyroidectomy is a shorter. You know that you will need to remove the right lower adenoma, so you make a smaller incision, go on the right side, remove this enlarged adenoma, and you would expect that this is what you need. There's a reduced risk of bilateral vocal cord paralysis. There is a reduced operative time and a high cure rate, more than 95%. But there is a risk of missing a second adenoma. Let's say we have found this right lower adenoma, and actually the patient have 2 adenomas, and you have removed one and you didn't remove the other one. But if you use one of the adjunctive tools, which is the intraoperative PTH, which I will mention later, then this risk is less. The standard is the bilateral 4-gland exploration. You will expose the 4 glands, have a look at them, remove the 1 enlarged, 2 enlarged gland. It is mentioned in the literature that there is a higher cure rate, and you're sure that you didn't miss at least one of the 4 glands. But you would do operation on both sides. There is a theoretical risk of bilateral vocal paralysis. There is a risk of hypocalcemia because you will do dissection and devascularization of many glands. But the main problem with this approach, I would say that it would make the revision surgery is very, very hard, because in this operation, you would need nice planes, less bleeding, so that you can identify the enlarged gland and remove it safely without causing devascularization of the other glands, without causing vocal cord paralysis. So revision surgery is very hard, and this is the main problem with starting the first operation by bilateral neck exploration. Our standard practice in Portsmouth, we would discuss with the patients, discuss the advantages and disadvantages of both approaches. If we have a well-localized adenoma on 2 scans, then we will offer them the targeted parathyroidectomy. The surgeon who does the targeted parathyroidectomy is ready to do the 4-gland exploration, bilateral neck exploration. This is actually will be this decision will be made in the operation based on the intraoperative PTH. So, how to do the parathyroid operation? You should know your anatomy, embryology very well. You need to know where is this enlarged gland and how and where to find it. As you may all remember that the superior parathyroid gland arises from the 4th branchial arch, and the lower parathyroid gland arises from the 3rd branchial pouch. So the superior parathyroid stays around the thyroid gland in the upper part behind it, where the lower parathyroid is related to the thymus. So it descends lower part in the neck with more variable rates. Sometimes you might have more than 4 glands. Sometimes you might have fewer than 4 glands. Usually, these other glands are not important and are not functional in the primary hyperparathyroidism. They are more important in the secondary hyperparathyroidism, tertiary hyperparathyroidism, or where you have Men's syndrome, because then there is a systematic or systemic stimulation for more parathyroid hormone secretion, and even a small group of cells, parathyroid cells, rest in the mediastinum or the thymus would produce parathyroid hormone. One very important factor to consider in this operation is the relation to the recurrent laryngeal nerve. The upper gland is behind the nerve. The lower gland is in front of the nerve. So if we draw a coronal plane that goes through the recurrent laryngeal nerve, the upper adenoma is behind this coronal plane, and the lower adenoma is in front of this lower plane. So this is very important, because sometimes you need to know where to find the nerve, how to protect it, and where to look for the adenoma when you know it's an upper or lower. Superior parathyroid adenoma usually dorsal to the superior aspect of the gland, within 1 centimeter of the upper pole, can sometimes be in the retropharyngeal, retroesophageal, or laryngeal. It's behind everything. Inferior parathyroid gland, 50% of patients or cases, it's around the lower pole of the thyroid gland, and sometimes below this lower pole, it's in front of the nerve. It can be in the thymus, or if it's ectopic, it can be in other different places like the carotid sheath or in the superior mediastinum. Sometimes, in very rare cases, it can be inside the thyroid gland. These are usually the lower parathyroid adenoma. This is the normal distribution of the parathyroid adenoma. This is the upper, usually, as we mentioned, behind the upper part of the upper part of the thyroid gland. Can even be a little bit more higher, sometimes a little bit on the lateral aspect when the gland is rotated. And this is where to find the lower parathyroid adenoma, below the thyroid gland, in relation to the thymus. Sometimes can be a little bit medial or lateral to that. This is where we can find the ectopic parathyroid gland, so retroesophageal, retropharyngeal, or in the mediastinum around the thymus. This is a very common place to find the parathyroid adenoma, and you can find it in the thyroid gland. This is also another site. Parathyroidectomy operation, how we do this in Portsmouth, we have a lot of tools, and actually this is very important. In Portsmouth, we have 3 adjunctive tools which help us in the parathyroidectomy. Number 1 is the ultrasound. The parathyroid surgeon would do an ultrasound himself. It can gives us a lot of information, where to find the gland, and if there are other than more than one gland enlarged. We have the intraoperative PTH machine. It is the NBCL. It's in theater, gives us the reading of the parathyroid hormone level in 5 minutes. And we have the flow optics, the near infrared camera, which helps us in the autofluorescence of the parathyroid gland. As a standard, we use nerve monitor in all cases. When the case is difficult, we use continuous nerve monitors. We use continuous nerve monitor in all our thyroid cases at the moment. So we do the incision, we raise subphalangeal flaps, find the strap muscles and retract them. We don't need usually to resect or cut the strap muscles. And then we identify the carotid and vagus, and this is the nerve monitor. We stimulate the vagus to make sure that the nerve, to have vagal stimulation before the operation, before the start of the operation. And then we can identify the parathyroid adenoma and remove it. This is the lower one. And then we can have a cheat a bit by doing the autofluorescence. The autofluorescence can give you a clue that this structure you are looking at is actually a parathyroid gland. You can see here how this parathyroid gland is glowing, different from the thyroid, different from skin, different from everything. We use it in all our thyroid and parathyroid cases, and I have to say it is very helpful. As you can see here, this is the parathyroid adenoma. It's very obvious. This is the thyroid gland, and this is the parathyroid adenoma, very obvious. And this is the thyroid and parathyroid adenoma. This is a parathyroid adenoma on the thyroid gland. This is a parathyroid adenoma. Here. So it is very helpful tool. We use it in all our operations, in all our thyroid and parathyroid operation, and it gives a lot of information. Using the intraoperative PTH, we follow the Miami criteria. Miami criteria, when you have 50% drop from the highest pre-excision level. So we usually have 3 to 4 levels, parathyroid hormone levels, one which was induction, second sample which is pre-excision, and then another sample 10 minutes, should be 10 minutes post-excision. If you have 50% or more drop in the parathyroid hormone level, you would expect very high cure rate. The theory behind that is that with manipulation in the neck around the thyroid and parathyroid gland, you would expect the parathyroid hormone level might become higher. So you need to see 50% drop from this high concentration. Because if you have a large adenoma, the induction level parathyroid hormone might be like 20, but the pre-excision level might be 40. And then 10 minutes post might be 15. Then you have more than 50% drop than the pre-excision one, but actually not a very percent of drop from the induction one. So you need to do this pre-excision one. There are other criteria. These are the standard criteria used by different centers. There's the Miami criteria, Vienna, Rome, and Hale. All these criteria are similar. They want to see a lot of drop in the parathyroid hormone level. Some of them wouldn't do the pre-excision. Some of them would want to see goes into the normal range. The main problem on all of these is that the negative predictive value. If you have more strict criteria, then the negative predictive value will go low. Negative predictive value mean that you have actually cured the patient, but the tests tell you that you haven't. And then you would continue looking, which adds operative time, risk of complication, devascularization. So you would need, ideally, a test that was a very high positive predictive value, but with high negative predictive value. Then when you have done the job, it will tell you that you have done the job. Doesn't tell you that you haven't, then you will continue. In the Hale criteria, you need to see that's very strict. It's within 15 minutes a big number of drop, or you need to be in the normal range. That's very difficult. And they want to see drop during the time from 20 minutes, then the 10 minutes you see a big number of drop. That's very difficult. It might not happen in the physiology. The body doesn't react like that. So this is a problem with other criteria. Miami, I would say, is the most sensible one, and we follow it at the moment, more or less. If you have done the job, remove the enlarged adenoma, and actually it doesn't fall, there might be another one. So you will do bilateral neck exploration for blend exploration, look for inside the carotid sheath, behind the larynx, behind the pharynx, thymus, thyroid, anterior and posterior mediastinum. You need to have a ladder or a plan in your mind. You will do a focused parathyroidectomy targeted one if you have an enlarged adenoma that's been detected on the scans. If you know that you have parathyroid hyperplasia in the secondary, tertiary condition, or multiple glands on the scan, you will do bilateral exploration. After doing that, and you haven't found it, or you haven't have a reasonable drop in the parathyroid hormone level, you will do central neck dissection. You will remove the thymus. You might remove partial thyroidectomy, hemithyroidectomy. Total thyroidectomy is very, very rarely done. I don't think we have done this at all before. In our series, we have seen in different places. We have seen an upper gland above the upper pole, in the carotid sheath, behind the pharynx, behind the larynx, behind the esophagus. We have seen in the mediastinum next to the heart. I've seen one in the submandibular gland. Mr. Matt Ward, my colleague, has found one there. There are other adjunctive tools that we don't use in our hospital, but other centers might use it, which is the lab intraoperative PTH. This takes about 40 minutes. So usually you would wait about 15 to 20 minutes after the excision to do it. Then this means that you need to wait an hour at least to have the answer, which might tell you that you're not successful. You need to continue. Some centers would use a frozen section. Frozen section would not confirm the cure. It will just tell you if this gland is a parathyroid or not. It cannot differentiate between parathyroid hyperplasia from adenoma. So it just tell you if this is parathyroid or is it a lymph node or a thyroid. Gamma probe can be used intraoperatively, but it's not standard in many centers now with the using the flow optics near infrared camera. Methylene blue is not licensed in the UK, but other centers might use it. It gives blue coloration for the parathyroid gland, parathyroid adenoma. Other optical technologies are not standard in many centers. Post-operative care. So majority of cases, it's overnight stay, no drains, calcium check day 1, and then parathyroid hormone, vitamin D, calcium check 3 months, and then follow up after that to see if the patient have been cured or not. Complications. No one likes complications, but it does happen. We all know that. So recurrent laryngeal injury might happen. In our hand, the incidence is low. It is about 5% or less than 5% for temporary, less than 1% permanent vocal cord paralysis. We do flexible nasal endoscopy day 1 after all our thyroid and parathyroid cases, so we know exactly if the patient would have developed that. The patient might develop hypocalcemia, hungry bone syndrome. We would expect that in very high calcium level before the operation, or failure. This is unlikely. Hematoma infection might happen. Recurrent hyperparathyroidism is very, very, very low. Possibility is less than 1%. Then we would review the patient in clinic 4 months. If the patient is cured, we will discharge to the GP with a recommendation for annual calcium check for 5 years. If they have persistent hypercalcemia, persistent disease, we will have another discussion. We might discuss to observe, we might opt to observe if the condition is mild. We might repeat scans trying to find it. We might consider other diagnosis if it could be like FHH. Our case series in the last 3 years, we have done 213 patients in the last 3 years, including with COVID. Our success rate is 98.6%. Our failure rate is 1.4%. We actually have found a single adenoma in 91% of the patients, 2 adenomas in 7.5. Hyperplasia we found is actually 1%. In the last 3 years, we didn't see any patient with parathyroid carcinoma. In our hospital, we have managed before 2 or 3 patients, but this is a very, very rare condition. So just to like give you this, it's just a small advice. The way to get started is just you have to begin doing this. And it's very, thank you very much. Any questions?
Thanks, Hani, for your nice presentation.
You are muted.
Thank you. Thanks, Hani, for your nice presentation. Sorry for this. It just I think there is few comments in the chat. If you can you see the chat? Yeah, I think there is one comment there. Anyone want to ask? He can just unmute himself and ask the questions. Can you read the questions?
Hani, I'll read you the questions. Hello.
Okay.
So there was one question. What's the difference between a targeted parathyroidectomy and a minimally invasive parathyroidectomy?
So it's not a big difference. The minimally invasive parathyroidectomy, you should do a very small incision overlying where the adenoma is. No dissection, no identification of any structure, just on top of that and remove it. Usually the incision is lateral, not midline. Where the targeted, what we call a targeted parathyroidectomy, we do it in our center where we do a standard incision, do standard steps, and then we just don't look for the other glands. We just remove the one gland, which is the enlarged gland identified on the scan, either it's upper or lower.
Hani, I just I do a lot of things in the same time. So the people, if they have been outside the meetings, I have to readmit them. So that's why I'm a bit busy. But that's fine. And I think Mr. Salim wants to say something. Is that correct? Ahmad? Say excellent presentation. What are you? Yeah.
So how there is a question here. What's turnover time for the intraoperative PTH? So in this NCBL, it's 5 minutes. There is no turnover time because the machine is in the operation, so we don't send it to the lab. So it's 5 minutes. We just take the sample and put it in the machine. Other question is, how do you do the fluorescence? It's an autofluorescence, so we don't inject anything. It's a near infrared spectrum, and then you would see the glow. It's not clear yet why this is happening. The current theory is that there is calcium sensing protein or receptors. This is the glowing structure in the parathyroid gland, but we don't inject anything. In other operations, like the thyroid operation, we inject the ICG, indocyanine green. It doesn't help in identification of the parathyroid gland. It helps in the identification of the vascularity of the parathyroid gland, the viability of the parathyroid gland. So there is the NIFTY trial, which they see the correlation between that and the post-operative calcium level. We use it when we do the total parathyroidectomy or total thyroidectomy or completion thyroidectomy. What is the chance of patient's symptomatic improvement post-operatively? This is expected. We, in our discussion with the patient before the operation, we say that more than 70, we expect to see more than 70% chance of improvement of the symptoms, especially the bone pain, joint pain, brain fog. Some of the patients who are actually asymptomatic before the operation would tell you after the operation that they feel differently, they feel more alive and active. So they might not know that they have symptoms because of this disease. Do we need to repeat PTH during follow-up? Yes, yes. So we do PTH day 1, PTH from 6 weeks to 3 months, 6 months after the operation, as with calcium and vitamin D levels. The cure of this disease is actually depends on, you would see it on the calcium level, not the parathyroid hormone level. Up to 12 to 18 months after the operation, you might still have some high parathyroid hormone levels, especially in older age and patient who have a high parathyroid hormone levels, very high parathyroid hormone level for a long time. But the cure of the disease is the calcium level. So we would consider the case has been cured when the patient has a normal calcium level 6 weeks, 3 months, 6 months after the operation. If the calcium level is not normal, then this patient has a failure. While if the parathyroid hormone is still high, that's fine. That's usually either a secondary because of the vitamin D, low vitamin D, or just a delayed response to the operation. What's your approach to confirm the parathyroid gland interoperatively is less than 1 centimeter? I don't understand this question.
Thank you for taking my question. Just I'm asking if it's really small, tiny one, less than 1 centimeter, sometimes surgically, it's very difficult to find it. Do you do anything different from what you do normally?
No. So yeah, we sometimes see a very small parathyroid gland, and especially in a mild disease when the calcium is 2.65 and the parathyroid hormone is just about 9 or 8. Then we don't expect to find a huge adenoma or multiple disease. We find one adenoma. Usually the color is different. The shape is different. Histologically, they can say it's an enlarged gland by the weight of that, usually more than normal. The normal is up to 50 microgram. An adenoma would be considered an adenoma, I think, if it's more than that, when it's 200, 300, 500, then this is an adenoma. But it's just the shape of it.
Any other questions? Okay, just to remind everyone that we would like to have the CD points. Just please put your email there. I will send you your certificate. All of the grand rounds have 1 CD point from the Royal College of Edinburgh, so you will receive the certificates once you put your email there. So please don't forget to put the email down in the comments, please. And anyone want to ask?
Do you follow the Bates guidelines for the post-operative hypocalcemia? So we have guidelines in our hospitals, which is similar to the other guidelines for the hypocalcemia. When it's just it depends on the calcium level and the parathyroid hormone level. If it's the calcium below 2.2, from 2 to 0.2, we just give oral calcium. And if it's less than that, less than 1.8, we might consider IV calcium shots and vitamin D when it's persistent.
Any other questions?
Yes, we tend to use the Nifty trial. Yeah, exactly. Yeah.
I think so. Any significant difference between using continuous versus nerve stim in your practice?
We, as a standard, we don't use continuous nerve monitor in the targeted parathyroidectomy. We use it in thyroidectomy. I think it's a good way of doing the operation, that you would all the time know that the nerve is functioning. It saves you time of confirming the integrity of the nerve. But we don't, as a standard, use it in the targeted parathyroidectomy.
I think so. We on time. Thanks, Hani. Really nice presentation. You know, I'm not the head and neck person, so I do otology and rhinoplasty, but it's really interesting to know and keep updates. So thanks for your updates. And I think that a lot of people enjoyed it. I can see that we are more than 45 person to this meeting, late one. So this is good indication of that everyone was really interesting in the topics. And I think so also on the YouTube later there will be a number of people who haven't attended, or there was a bit late time for them, so they will watch it. So thank you for this for your time. And I think thanks for Mark as well. I can see is one of your colleagues seem to be answering as he's answering.
My parathyroid colleague and friend.
Yeah, thanks for joining. So and I know it's a far distance, but thanks for the teams that make it more easy for everyone to meet and join their little things, their ideas. So again, see you later. Please, anyone get it difficult to write his email down, or he couldn't get his certificate, just send me directly an email. I will send the certificate for him. Thank you. Thanks, Hani. Enjoy the rest of the evening. Thanks. Bye.